Role of a surgeon in ulcerative colitis, UC. Ulcerative colitis is a chronic inflammatory condition of the colon and rectum. While medical management is the primary approach for controlling symptoms and achieving remission, surgery plays a crucial role in specific scenarios. Surgeons specializing in colorectal surgery are involved in treating patients with UC who do not respond to medical therapy, experience severe complications, or develop precancerous or cancerous lesions. Below is a detailed account of the surgeon's role in managing ulcerative colitis. 1. Indications for surgery. Surgeons intervene in UC under the following circumstances: failure of medical therapy, when symptoms are not controlled despite optimal medical management, including immunosuppressants and biologics; acute severe ulcerative colitis, ASUC, emergency situations where medical therapy fails to resolve toxic megacolon, severe bleeding, or perforation; complications: toxic megacolon, life-threatening colonic distension; perforation, requires immediate surgical intervention to prevent sepsis; severe rectal bleeding, persistent or life-threatening hemorrhage; dysplasia or cancer, when surveillance colonoscopy identifies high-grade dysplasia or colorectal cancer; growth retardation in children. Surgery may be considered if UC impairs growth and development in pediatric patients; quality of life concerns, patients with debilitating symptoms impacting daily living despite medical therapy. 2. Surgical procedures. Surgeons perform different types of procedures depending on the patient's condition and overall health. A. Total proctocolectomy with ileal pouch anal anastomosis. Procedure: removal of the colon and rectum, followed by creating a J-pouch from the ileum and connecting it to the anus. Indication: standard surgery for patients with medically refractory UC or those at high cancer risk. Advantages: preserves continence and avoids a permanent stoma. Total proctocolectomy with end ileostomy. Procedure: complete removal of the colon, rectum, and anus, followed by creating a permanent ileostomy. Indication: suitable for patients unfit for IPAA or who prefer a permanent stoma. Advantages: eliminates disease and simplifies postoperative management. Subtotal colectomy with end ileostomy. Procedure: emergency removal of the colon, leaving the rectum intact for later surgery. Indication: used in acute settings such as toxic megacolon or perforation. Advantages: stabilizes the patient and provides time for recovery before definitive surgery. Neher 3. Preoperative assessment. Surgeons work with a multidisciplinary team to optimize patient outcomes. Medical optimization, ensuring infections are controlled and medications such as corticosteroids are managed. Nutritional support, addressing malnutrition and anemia through supplements or parenteral nutrition. Psychological preparation, educating patients about the procedure, outcomes, and potential lifestyle changes. 4. Postoperative care. Surgeons oversee recovery and management of complications, monitoring for complications, anastomotic leaks for IPAA, pouchitis in IPA patients, stoma-related issues for ileostomy, long-term follow-up, surveillance for pouch function and pouchitis, nutritional counseling to manage absorption changes, support for lifestyle adaptations, especially for patients with ileostomies. 5. Role in emergency situations. In life-threatening cases like toxic megacolon or perforation, immediate surgery, typically subtotal colectomy with ileostomy, is performed to stabilize the patient. Post-emergency care involves planning definitive surgery once the patient recovers. Part 6. Multidisciplinary approach. Surgeons collaborate with gastroenterologists to decide the timing of surgical intervention, pathologists for histological analysis of resected tissues, dietitians for managing postoperative nutrition, psychologists or support groups to help patients adjust to life after surgery. 7. Outcomes and prognosis. Surgical intervention in UC often leads to excellent long-term outcomes, with resolution of disease and improved quality of life. For IPAA patients, maintaining pouch function is crucial for optimal results. Permanent ileostomy patients can lead normal, active lives with proper education and support. In summary, the role of a surgeon in ulcerative colitis extends beyond performing operations. They are integral to the multidisciplinary care team, providing expertise in determining the right timing and type of surgery, addressing complications, and ensuring comprehensive postoperative care for improved patient outcomes.